whereas decreased resonance is seen in consolidation, collapse, abscess, tumor, fibrosis. Stony dullness is seen in pleural effusion. Breath sounds. Assess the character of the breath sounds and added sounds. Bronchial breathing. Breath sounds are harsher than normal and there is an audible gap in between inspiration and expiration is bronchial, often caused by lung consolidation due to pneumonia. Decreased breath sounds. Consider pleural effusion or pneumothorax, emphysema or lung collapse. Added sounds. Pleural rub, wheeze, crepitations and crackles. Wheeze. Musical sound heard during expiration. Polyphonic wheeze, narrowing of many small airways, typically of asthma or COPD. Monophonic indicates a large airway obstruction due to a foreign body or a tumor. Wheeze is heard in expiration. Page number 269. Crackles in the chest, produced by airflow moving secretions. Fine crackles. Consider pulmonary edema. Early inspiratory crackles, usually best heard at the bases at the back. Early pneumonia, fibrosing alveolitis, or late inspiratory crackles. Coarse crackles. Consider tuberculosis, resolving pneumonia, bronchiectasis, or lung abscess. Pleural rub. Creaking sound produced by movement of visceral over the parietal pleura when both are inflamed, that is either in pneumonia or an infarction. Pleural effusion. Fluid in the pleural cavity. Simple effusions may be transurates less than 30 grams per liter of protein or exudates more than 30 grams per liter of protein. Effusions may also be blood, lymph, pus, empyema. Causes of simple effusion are malignancy, example lung cancer, mesothelioma, Meeks syndrome, infection like pneumonia or TB, infarction like pulmonary embolus, heart failure, constrictive pericarditis, inflammation, SLE or rheumatoid arthritis, pancreatitis, asbestos exposure, hypoproteinemia, and hypothyroidism. Presentation may be incidental finding on chest X-rays. Symptoms are dyspnea and pleuritic pain, symptoms of underlying cause, signs absent breath sounds, dullness to percussion, decreased tactile or vocal primitus, decreased vocal resonance. Above the effusion, there is usually a zone of bronchial breathing. Early on, there may be pleural rub. Large effusions shift the mediastinum away from the affected side and there may be a decreased chest wall movement. Confirm with an X-ray. If cause is not apparent, refer for diagnostic tapping. Management. Treat the underlying cause. Refer for drainage if symptomatic and repeat drainage plus pleurodesis may be necessary. Surgical emphysema. Air in the subcutaneous tissue can be caused by spontaneous pneumothorax or trauma to the chest wall. Tissues appear swollen and crackle on palpation. So chest signs associated with common chest pathology. Mediastinum, consolidation, example. So these are the four chest conditions: consolidation, pleural effusion, collapsed lung and pneumothorax. Let us see what are the chest signs we can elicit. In consolidation, the mediastinum is not, like pneumonia, mediastinum is not displaced and there is decreased expansion. Percussion is dull, bronchial breath sounds, crackles or rub is seen, and there is increased vocal resonance or whispering pectorilocally. Pleural effusion. Normal or displaced when there is a pleural effusion on one side, mediastinum can be normal or displaced away from the side of the effusion if it's large effusion. Expansion is decreased. There is stony dullness. The bronchial the breath sounds are decreased in pleural effusion. Bronchial breathing above the effusion. Decrease in vocal resonance. Collapsed lung. Displaced towards the side of the collapse, there is decreased expansion, dull on percussion, decrease in breath sounds, and there is no added sounds. Whereas in pneumothorax, the mediastinum is displayed away from the side of the pneumothorax, expansion is decreased, is hyperresonant, and decrease in breath sounds. Even though it is hyperresonant, the breath sounds are decreased, no added sounds, decrease in vocal resonance. Respiratory medicine. 270. Other signs of respiratory disease. The trachea. Palpate the trachea and the supraclavicular notch. If it is in the midline, notch in the midline. Deviation to the left or right suggests a shift of the upper mediastinum to that side. The distance between the suprasternal notch and the cricoid cartilage in an adult is 2 to 3 finger breadths. If it is less than this, the lungs are probably hyperinflated. Weight loss. Non-specific symptom or sign, consider GI causes like malabsorption, malnutrition, dieting, chronic diseases like hyperthyroidism, diabetes, COPD, heart failure, renal disease, degenerative neurological or muscle disease, chronic infection like TB or HIV. Malignancy. Psychiatric causes like depression, dementia or anorexia. Offer an urgent chest x-ray to any patient more than 40 years with an unexplained weight loss if he ever smoked or exposed to asbestos, or he never smoked but with any other of the following, that is cough, fatigue or shortness of breath, or chest pain or loss of appetite. Cachexia. Severe generalized muscle wasting. Causes are neoplasia, malnutrition, chronic infection like TB and prolonged inactivity, dementia. Night sweats. Consider tuberculosis, lymphoma, leukemia, solid tumor. Example are renal carcinoma, menopause or anxiety states. Erythema nodosum 568, peripheral edema 204, Horner syndrome. Sympathetic nerve disruption to the iris causes a small meiotic pupil with lack of pupillary dilatation in the dark, partial lid ptosis, and hydrosis of the forehead, plus or minus, may be present or not present, anophthalmos. This is Horner syndrome. Sympathetic nerve disruption leading to a small pupil with lack of dilatation in the dark, partial lid ptosis, anhidrosis may be present or absent, and ophthalmos. Causes are Pancoast tumor, cervical cord, or mediastinal tumor. Either it's a Pancoast tumor, cervical cord tumor, or mediastinal tumor. Aortic aneurysm, posterior inferior artery or basilar artery occlusion, hypothalamic lesion, or syringomyelia. So these are the causes: Pancoast, cervical cord tumor or mediastinal tumor, aortic aneurysm, posterior inferior artery or basilar artery occlusion, hypothalamic lesion or syringomyelia. Pallor. Check the eyes and mucous membranes for pallor suggesting anemia. Cyanosis. Persistent thrombocytosis. Flapping tremors or asterixis. Bilateral motor disturbance. Ask the patient to hold his hands straight out in front of him and dorsiflex his hands. This provokes a flapping asynchronous tremor which is absent at rest due to carbon dioxide retention in severe COPD. Lymphadenopathy. Consider an urgent chest X-ray in any patient more than 40 years with supraclavicular lymphadenopathy or persistent cervical lymphadenopathy. Consider an urgent referral using a suspected cancer pathway if there is an unexplained neck lump in a person more than 45 years or there is a persistent unexplained neck lump in a person less than 45 years. Clubbing. Consider an urgent chest X-ray to assess for lung cancer in people more than 40 years with a finger clubbing. Yellow nails, hoarseness. Consider a suspected cancer pathway referral for laryngeal cancer in people more than 45 years with persistent unexplained hoarseness. Stridor, jugular venous pressure. Further information you can see on the website. Respiratory investigations. Indication for an urgent chest X-ray. If more than 40 years and 2 or more of the following are present, or if previously smoked or exposed to asbestos, more than one of the following should be present. That is, unexplained symptoms of cough, fatigue, shortness of breath, chest pain, weight loss, appetite loss. Any of the following. Persistence of or if more than 40 years and any of the following is present, like persistent of recurrent chest infections, finger clubbing is there, supraclavicular or persistent cervical lymphadenopathy, chest signs consistent with lung cancer or pleural disease, or thrombocytosis. Persistent thrombocytosis, also you have to do a chest x-ray. Incidental findings on chest x-ray or CT of emphysema or signs of chronic airway disease. Perform respiratory review and spirometry. Treat according to the results. If no symptoms and a normal spirometry, if he is a current smoker, offer smoking cessation advice. Increase because there is an increased risk of COPD or lung cancer. Advise to return if new symptoms are present. If he is a non-smoker, ask about the family history of lung or liver disease. Consider an alpha-1 alpha antitrypsin deficiency. Advise to return if new symptoms are there. Peak flow. Simple and cheap test. Poor measure for airflow limitation tends to overestimate the lung function. Best used to monitor progress of a disease and effects of treatment for patients with asthma. Link with self-management plan. Meters are available on the NHS prescription. EN23747. EU standard peak flow meters are supplied. Charts are available from NHS supplies and drug companies. Measuring peak expiratory flow rate. Normal values are given in the table. Ask the patient to stand up if possible and hold the meter horizontally. Check the indicator at 0 and the track is clear. Ask the patient to take a deep breath and blow out forcefully into the peak flow meter, ensuring the lips are sealed firmly around the mouthpiece. Read the PEFR of the meter. The best of the three attempts is recorded. Consider using a low range meter if predicted, or best PEFR is less than 250 liter per minute. Okay. Spirometry measures of volume of air the patient, adult or child more than 5 years, is able to expel from the lungs after a maximal inspiration. FEV1, forced expiratory volume 1, volume of air the patient is able to exhale in the first second of forced expiration. FVC, total volume of air the patient can forcibly exhale in one breath. FEV1 or FVC by FVC is a ratio of FEV1 by FVC expressed as a percentage. Measuring the FEV1 by FVC interprets the result. Interpretation of results is seen in table 10.3. Normal values, table 10.5. Sit the patient comfortably. Ask the patient to take a deep breath in. This is for measuring the FEV1 or FVC in a sitting position, whereas peak flow is in standing position. Ask the patient to blow the whole breath out as hard as possible until there is no breath left to expel, and ensuring the lips are sealed firmly around the mouthpiece. Encourage the patient to keep breathing out. Repeat the procedure for 2 times, 3 attempts in all, and more than 2 readings should be within 100 ml or 5% of each other. Flow volume measurement. RCP 3 questions. Useful tool to identify the patients with poor asthma control in general practice and monitor the effects of change of treatment. Morbidity categories correlate with lung function. In the last month, have you had? So these are RCP 3 questions which help in seeing the control of asthma. Have you had any difficulty sleeping because of your asthma symptoms, including cough? Have you had your usual asthma symptoms during the day, cough, wheeze, chest tightness, or breathlessness? Has your asthma interfered with your usual activities, example housework, work, or school, etc.? If no is answer, then low morbidity. If 1 or yes is the answer, medium morbidity. 2 or 3 is the answer, then high morbidity. So daytime symptoms, difficulty sleeping due to nighttime symptoms, and interfered with usual activities like miss school or work. Alternatives to include asthma control questionnaire and asthma control test or children asthma control test. So these are the alternatives. Otherwise, first one is RCP 3 questions. These questionnaire are not designed during or for use during an attack. That is only for control and monitoring of treatment. Obstructive picture. So this is a flow volume curve for patients with restrictive and obstructive lung disease, reproduced from BTS guidelines. It's an obstructive picture. This is a normal curve, flow volume curve, and then this is the restrictive curve, the one in the blue, and obstructive curve. Restrictive picture. This is a normal curve, and this is the restrictive curve. Here there is a concave curve in obstructive disease. Flow volume curves is done. Interpretation of spirometry results. Restrictive lung disease, obstructive lung disease. Restrictive lung disease example interstitial lung disease, obstructive lung disease example COPD. In restrictive lung disease, the FEV1 percentage of predicted normal is less than 80%. The FVC, forced vital capacity of predictor of normal, is less than 80%. FEV1 by FVC ratio is normal or more than 70%. Obstructive lung disease, FEV1 is less than 80%. FVC is normal or decreased, and FEV1 by FVC ratio is decreased, that is less than 70%. Predicted PEFR measurements in liter per minute EU scale. In children, height is the only determinant for PEFR in children. With increase in age, the pattern of adult values take over. Okay, these are the tables. You can read by yourself. I'm not sure whether we have to remember this or not. So, depending upon your age and height, the peak expected flow rate increases. So after 40 years, so by 40 years, your flow rate increases, and then after 45 years, by 45 years, your flow rate starts decreasing gradually till 70 years. In men after 35 years, the flow rate decreases. Also correlates with height and age. So these are the values for Caucasians. Decrease values by 7% for Asians. These values apply for Caucasians. Decrease the value by 7% for Asians and 13% for people of Afro-Caribbean origin. These are the predictor values, okay? And then you have to compare the current obtained values with the predicted values when we are comparing as a percentage, like FEV1 and FVC. We are comparing as a percentage of predicted values. So these are the predicted values. Bronchodilators and steroids. Bronchodilators cause relaxation of the bronchial smooth muscles. Short-acting beta-2 agonists, salbutamol, terbutaline, safest and most effective beta-2 agonist for use as a quick reliever in asthma and COPD. Duration of action is 3 to 5 hours. Oral preparations are less effective than inhaled preparations. Prescribe as 1 to 2 puffs PRN. Warn the patients to seek medical advice if usual dose does not relieve the symptoms or relieve symptoms for less than 3 hours. Regular treatment with bronchodilators alone may be linked with worsening of asthma and asthma deaths. If the patient has asthma and using a beta-2 agonist inhaler more than 3 times a week, consider a prophylaxis, that is with a MART therapy. Longer acting beta-2 agonists, salmeterol and formoterol. Asthma, example salmeterol 50 to 100 micrograms BD as an adjunct to existing corticosteroid treatment, particularly useful for nighttime asthma. So, SABA and LABA. This is LABA. It is used after you have started on ICS with SABA. Duration of action is 12 hours. Due to rapid onset of action, formoterol can also be used to relieve acute attacks, usually in combined with steroid inhaler or LABA inhaler as a part of maintenance and reliever therapy. So what is maintenance and reliever therapy? In this, there is a long-acting formoterol, which is short, rapid onset of action is there, which can be used both for acute attacks and maintenance therapy. So that is SMART. COPD. Always We have already read about it. Always prescribe a combination inhaler with inhaled steroids. Short and long-term treatment of inflammatory conditions. Oral steroids prescribe a single dose in the morning, often started at a high dose, 40 to 50 milligrams OD, to suppress the disease process and then stopped after improvement. If used as maintenance therapy, use minimum dose that controls the disease. Supply with a steroid card. Inhaled steroids. Usually used regularly to obtain maximum benefit. Elevation of symptoms occur 3 to 7 days after initiation. If causes coughing, try a short-acting beta-2 agonist before use. Common unwanted effects are oral candidiasis and hoarseness. Reduce the use by large volume spacer or a mouthwash after use. Beclomethasone inhalers should always be prescribed by brand name. See, beclomethasone inhalers always prescribed by brand name. Side effects of oral and high dose inhaled steroids. Oral and high dose inhaled steroids. So, high BP, osteoporosis or fracture, proximal muscle wasting, euphoria, paranoid states or depression, especially if PMH, uh, peptic ulceration, no PO soluble or EC preparations when decrease the risk. Suppression of clinical signs may allow diseases, example septicemia, to reach advanced stage before being recognized. Spread of infection, example chickenpox. Diabetes mellitus, worsening of diabetic control. Cushing syndrome, moon face, striae and acne. Adrenal atrophy can persist years after stopping long-term steroids. Illness or surgical emergencies may need to be covered with a steroid supplementation. Growth suppression in children, sodium and water retention and potassium loss. Steroid cards should be carried by patients on oral or high dose of inhaled steroids. This card informs other practitioners that the patient is on steroids and gives patient advice on use of steroids and risk of infection. Steroid cards can be obtained from that particular number. Withdrawal of steroids. Stop abruptly if disease is unlikely to relapse. The patient has received treatment for less than 3 weeks and is not included in the following patient groups. Withdraw gradually if the disease is likely to relapse and the patient has recently had repeated steroid courses, particularly if taken more than 3 weeks, taken a short course less than 1 year after stopping long-term therapy. Other possible causes of adrenal suppression: received more than 40 milligrams OD of prednisolone or equivalent for more than a week, been given repeated doses in the evening, received treatment with steroids for more than 3 weeks. So these are the conditions where you have to taper the dose of steroids. Otherwise, in other conditions where it has been given for less than 3 weeks, you can stop abruptly. During corticosteroid withdrawal, decrease the dose rapidly to physiological levels. Prednisolone 7.5 milligrams OD. Thereafter, decrease more slowly. Assess the disease during withdrawal to ensure relapse does not occur. Use of spacers with meter dose inhalers. Advantages of using a spacer: allows more time for evaporation of propellant, so larger proportion of active drug is deposited into the lungs and there is no need to coordinate actuation and inhalation, and results in less oropharyngeal side effects. Example, thrush, hoarseness or inhaled steroids. With inhaled steroids. Use of spacers. Both large volume spacers, volumatic, and medium volume spacers, aerochamber, are widely available, acceptable and portable. Inhale the drug from the spacer immediately after actuation as the effect of the drugs is short-lived. Spacers should be washed and air dried monthly to prevent buildup of electrostatic charge affecting drug delivery and replaced every 6 to 12 months. Home nebulizer therapy. In England and Wales, nebulizers are not available via the NHS but are free of VAT. Some nebulizers are available in Scotland in the form of GP110A. Nebulizers convert a solution of a drug into an aerosol for inhalation. They are used to deliver high dosage of drug than in usual with inhalers over a short period of time, that is 5 to 10 minutes. Indications are acute exacerbations plus or minus, regular treatment of asthma, COPD, antibiotic treatment for patient with chronic purulent infection, example cystic fibrosis, bronchiectasis, prophylaxis and treatment of pneumocystis pneumonia with pentamidine in patient with AIDS. Palliative care: palliation of breathlessness and cough, bronchodilators and lidocaine or bupivacaine for dry persistent cough. These are the indications of a nebulizer used in asthma and COPD. Before suggesting long-term use, review the diagnosis, the technique using a handheld device plus spacer and compliance. Try increasing the dose of a bronchodilator via a handheld device for at least 2 weeks. Perform a 2-week trial of nebulizer therapy and monitor therapeutic effect. Example with PEFR in asthma or dyspnea score with COPD. Provide clear instructions on the use of nebulizer, monitoring, and when to seek help. Follow up regularly. Asthma in adults. Symptoms or signs of severe asthma attack. So in adults, symptoms and signs of a severe attack. This is severe attack. PEFR is 32 to 50% of predictor of the best. Oxygen saturation is more than 92%. He is unable to talk sentences. Tachypnea more than 25 breaths per minute. Tachycardia more than 110 breaths per minute. Life-threatening signs are PFR less than 33% of predicted, oxygen saturation less than 92. There's a poor respiratory effort. There's a silent chest, life-threatening sign, silent chest or inaudible wheeze, arrhythmia, hypotension, altered consciousness, cyanosis, and exhaustion. Management of an acute attack of asthma is there in page 1072. There are two competing national asthma guidelines in UK which differ significantly from each other. The guidance in this section is based on the BTS or sign guidance. Linked to both BTS and sign guidance and parallel NICE guidance are provided on page 281. Asthma is a condition of paroxysmal reversible airway obstruction that affects 1 in 12 adults in the UK. It has characteristic features: airflow limitation, usually reversible spontaneously or with treatment, airway hyperresponsiveness to a wide range of stimuli, inflammation of the bronchi. Asthma in special groups are in children, in occupational asthma, and pregnancy. Diagnosis of asthma. Characteristic pattern of symptoms and signs and tests without other explanation determine probability of asthma. High. Recurrent episodic asthma symptoms more than one wheeze, breathlessness, chest tightness, more than one of wheeze, breathlessness, chest tightness, cough, diurnal variability, audible expiratory wheeze, documented variable airflow obstruction, PEFR variability, atopic history, absence of features to suggest another diagnosis. Intermediate risk are, probability are, some features of asthma and poor treatment response. Low risk, low probability, no typical asthma features, symptoms suggest other diagnosis. Always consider the possibility of occupational asthma. Are the symptoms better on a day off work? Are the symptoms better on a holiday? If yes to either or both, consider referral. Clinical features that decrease the probability of asthma. Normal chest examination or PEFR or spirometry when symptomatic, chronic productive cough without wheeze or breathlessness, prominent dizziness, lightheadedness and peripheral tingling, voice disturbance, symptoms with cold only, smoking history of more than 20 packs per year, and cardiac disease. These are the symptoms, clinical features that decrease the probability of asthma. Normal spirometry. When asymptomatic does not exclude asthma. So during a symptomatic or acute attack only you have to do a spirometry. That will be if it is normal then it excludes asthma, but not when asymptomatic. Test. Spirometry plus reversibility is the preferred initial test. Consider a chest x-ray with atypical or additional symptoms. Example symptoms. Eosinophil counts. So these are the tests. NICE advocates the use of fractional exhaled nitric oxide testing. Differential diagnosis. Airflow obstruction, that is FEV1 by FVC less than 0.7. Airflow obstruction, no airflow obstruction. Airflow obstruction due to COPD, bronchiectasis, inhaled foreign body, obliterative bronchiolitis, large airway stenosis, lung cancer, sarcoidosis. No airflow obstruction. Chronic cough syndromes, hyperventilation syndrome, vocal cord dysfunction, rhinitis, GERD, heart failure and pulmonary fibrosis. May be associated with non-obstructive spirometry. Lung cancer and sarcoidosis, bronchiectasis, and an inhaled foreign body can be associated with non-obstructive spirometry. So this is the differential diagnosis of asthma. Action. High probability. When there is high probability, give a trial of treatment with inhaled beclomethasone 200 milligrams BD or equivalent for 6 weeks. If response is poor despite adequate inhaler technique and concordance, investigate further. If significant airflow obstruction, there may be inhaled steroid resistance. Treat with an oral prednisolone 30 milligrams OD for 2 weeks instead. Intermediate probability. Perform a spirometry. FEV1 by FVC is less than 0.7, that is airway obstruction is present. Offer reversibility testing or trial of treatment. If significant reversibility and trial of treatment is beneficial, treat as asthma. If insignificant reversibility and treatment trial is not beneficial, consider test for alternative diagnosis. If FEV1 FVC is more than 0.7, no evidence of airway obstruction, arrange further investigations. Example, challenge test or FENO testing to identify eosinophilic inflammation more than 40 parts per million billion is positive, indicating high likelihood of asthma before commencing treatment or referral. Low probability. Consider alternative diagnosis and investigate or manage accordingly. Consider asthma if there is no response. Reversibility testing. For patient with diagnostic uncertainty, if airflow obstruction is present at the time of assessment, assess the FEV1 and or symptoms before 20 minutes and after 400 micrograms of inhaled salbutamol via an MDI and spacer. If no airflow obstruction is present or response to inhaled salbutamol is uncertain, assess FEV1 or PEFR and or symptoms after trial of treatment with inhaled beclomethasone or equivalent for 6 weeks or oral steroids prednisolone for 14 days. So initially for reversibility testing you will use salbutamol, and if reversibility is present then it is asthma. If no reversibility with salbutamol, then you have to go for further testing. So you assess the FEV1 or PEFR or symptoms after trial of treatment with beclomethasone or equivalent for 6 weeks, and then oral steroids. If more than 200 ml increase in FEV1 suggests more than 400 ml increase strongly suggests asthma. If smaller improvement, decide whether to continue treatment by assessment of symptoms. Trial of treatment withdrawal may be helpful if in doubt. Reasons for referral in asthma. Severe asthma exacerbation, emergency referral. Monophasic wheeze or stridor, emergency referral. Chest X-ray shadowing is urgent referral. Prominent systemic features, myalgia, fever, weight loss, urgent or soon. Diagnosis is unclear, soon or routine. Unexpected clinical findings. Example, crackles, clubbing, cyanosis, soon or routine. Constant breathlessness, soon or routine. Poor response to treatment, soon or routine. Unexplained restrictive spirometry, routine referral. Suspected occupational asthma, routine referral. Chronic sputum production, routine referral. Eosinophilia, routine referral. Asthma management in practice. There are two competing national guidelines in the UK which differ significantly from each other. The guidance in this section is based on BTS sign guidance. A link to the parallel NICE guidelines is provided. Aims of treatment. To decrease daytime symptoms and nighttime awakening due to asthma, minimize the need for reliever medication, decrease the impact on lifestyle, example absences from work or school, exercise, prevent severe attacks or exacerbations, have normal lung function, FEV1 or PEF more than 80% of predicted or best, and decrease the side effects from medications. GP services. Routine asthma care should be carried out in specialized primary care clinics. Doctors or nurses involved need appropriate training and regular updates. Practices should keep an asthma register to ensure adequate follow-up and allow audit. Not all the patients want to attend a pre-arranged appointment. Telephone reviews may be as effective as face-to-face consultations. Reviews and monitoring. Frequency depends on needs. Aim to review all the patients with asthma at least annually. Check symptoms since last seen. Use objective measures like RCP 3 questions. Record smoking status and advise smokers to stop. Symptoms are include objective measures like RCP3, asthma ACQ and ACT questionnaires. So, symptoms. Smoking status, record, revise Advice about smoking cessation, exacerbations, number and the circumstances in which there was exacerbation, medications, use or concordance, problems or side effects, inhaler technique, examination, objective measures for lung function, example, PEFR and spirometry, education, tailored to the individual, treatment, monitoring, allergen avoidance and action plan, goals and next review. This is summary of annual asthma review. Record any exacerbations or acute attacks since last seen. Check the medication use concordance, the use of the medication concordance to the prescription, inhaler techniques, problems and side effects. If more than one SABA inhaler per month may have a poor asthma control, consider stepping up the treatment. This was a question. Check the influenza and pneumococcal vaccine received status. Review objective measures of lung function, example home PEFR chart or PEFR or spirometry at review. Address any problems or queries and educate about asthma. Agree management goals and date for further review. Self-management. All patients should receive self-management education. Brief, simple education like patient goals is most likely to be successful. Include information about nature of the disease, nature of treatment, how to use it, self-monitoring or assessment, recognition of acute exacerbations, allergen or trigger avoidance, patient's own goals of treatment. Written action plan. Focus on individual needs. Include information about symptoms, triggers, and peak flow levels that indicate when asthma is worsening, and guidance about what to do under those circumstances. Action plans decrease the morbidity and health costs for asthma. PEFR monitoring. Record PEFR at asthma review if acute exacerbation. Home monitoring plus action plan can be useful, especially in patients with severe asthma or brittle asthma, rapid development of acute attacks, and if poor perceivers of symptoms. Management of acute asthma. We'll see in page 1072. Non-pharmacological measures. Smoking may increase the symptoms of asthma. Advised to stop. Weight. There is some evidence that weight loss in obese patients with asthma result in increased asthma control. Allergen avoidance. House dust mite. There is little evidence that decrease in house dust mite results in clinical improvement. Physical and chemical methods can be of reducing dust mite levels are ineffective and should not be recommended. Example, arachides, mattress covers, vacuum cleaning, heating, ventilating, freezing, washing, air filtration and ionizers. Pets. There is no evidence that removing pets from a home result in improved symptoms, but many experts still advise removal of pet from the patient if patients with asthma also have an allergy to the pet. Drug therapy. For further information, go to that website. Drug treatment of asthma. There are two competing national guidelines in asthma in UK. Here they are giving SIGN guideline and link to NICE guideline is provided. Management of acute asthma in page 1072. Exacerbations. Treat early. The patients on 200 microgram doses of inhaled steroids. In adult patient on 200 micrograms of inhaled steroids, a 5 times increase in dose reduces the severity of exacerbations. Alternately, use prednisolone 30 to 40 milligrams OD for 1 to 2 weeks. So, any case of asthma exacerbation, you are supposed to start on a 30 to 40 milligrams OD prednisolone for 1 to 2 weeks. Most usually, they are saying 5 days. Use a stepwise approach. Start at the step most appropriate to the initial severity of symptoms. Achieve early control. Maintain control by increasing treatment if needed and decrease treatment if it is good control. Selection of inhaler device. If possible, use MDI. Inadequate technique may result in drug failure. Patient must inhale slowly and hold the breath for 1 second after inhalation. Demonstrate inhaler technique before prescribing and check at follow-ups. Spacer or breath activated devices are useful if patients find activation difficult. Dry powder inhalers are an alternative. Short acting beta 2 agonists. Example, salbutamol, terbutaline, SABA. Work more quickly and with fewer side effects than alternatives. Use PRN unless shown to benefit from regular dosing. Use more than 2 canisters per month or more than 10 to 12 puffs per day is a marker of poorly controlled asthma. Step up the dose. Budesonide or formoterol combination inhaler is an alternative rescue medication as a part of MART regimen. See, wherever formoterol is used, it is a part of MART regimen. Inhaled corticosteroids. Effective preventer may be beneficial for patients with mild asthma. Consider if exacerbation of asthma in the last 2 years required steroids using inhaled beta 2 agonists more than 3 times per week or Symptomatic, more than 3 per week or more than 1 night per week. So this is when you have to use an inhaled corticosteroid also along with a short-acting beta agonist. Oral steroids. Add-on therapy aims to improve lung function or symptoms. Before initiating a new drug, check for compliance, inhaler technique, eliminate trigger factors, only continue if demonstrable benefit is there. Inhale long-acting beta-2 agonist, example salmeterol. Although there is no difference in efficiency, combination inhalers are recommended to improve inhaler concordance. A MART regimen using steroid plus formoterol combination inhaler for both regular prevention and relief of acute symptoms is useful to decrease asthma attacks. Leukotriene receptor agonist, example montelukast, decreases the exacerbations. Theophylline, side effects are common, example nausea and gastric irritation. Complementary therapies. Buteyko breathing technique. Buteyko breathing technique decreases the symptoms. No convincing evidence of effectiveness to other therapies. Monoclonal antibodies, omalizumab and mepolizumab, may be considered in patients with high oral corticosteroid burden, always specialist initiated. Side effects include local skin reactions and anaphylaxis. Omalizumab and mepolizumab. Step 5. Specialist therapies, refer for specialist care. Step 4. Okay, we'll start from first step. So this is a figure showing summary of stepwise management in adults. Start treatment at the level most appropriate to initial severity, achieve early control, maintain control by increasing treatment as necessary and decrease treatment when control is good. Before initiating any new drug therapy, check adherence to the inhaler technique and elimination of triggering factors. Low dose is defined as the lowest dose recommended for an adult for a drug chosen. And NICE recommends adding a leukotriene receptor agonist before LABA as an initial add-on therapy. We'll see where it is. So step 1, mild intermittent asthma. Inhale short-acting beta-2 agonist as required. Step 2, regular preventive therapy. Add low-dose steroid if acute attack of asthma in last 2 years. Using a beta-2 inhaler or symptomatic more than 3 times per week and waking 1 night every week due to asthma. Then you use a regular preventer therapy. Initial add-on therapy. Regular preventer with SABA. Initial add-on therapy. Add an inhaled long-acting beta-2 agonist as a combination inhaler. Consider MART regimen if history of asthma attacks is present. So regular preventive therapy is with a low-dose inhaled steroid with SABA as and when PRN. But then step 3. If add an inhaled long-acting beta agonist as a combination inhaler, consider MART regimen if history of asthma attacks is present. Step 4. Additional controller therapies. Consider increasing inhaled corticosteroid to medium dose or add a leukotriene receptor agonist. If no response to LABA, consider stopping. Whereas NICE recommends here, before adding a LABA, you need to consider a leukotriene receptor agonist. If no response to LABA, consider stopping. Specialist therapies, refer for specialist care. Stepping down. The review and consider stepping down at intervals less than 3 months. Maintain on the lowest dose of inhaled steroid controlling symptoms. When reducing steroids, cut down the dose by 25 to 50% each time. Okay. Difficult asthma. Persistent symptoms or frequent exacerbations despite treatment at step 4 or 5. Check the diagnosis and exacerbating factors. Assess the adherence to medication. Find out about family, psychological or social problems that may be interfering with effective management. Further information. You can see those guidelines. Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease (COPD) is a slowly progressive disorder characterized by airflow obstruction. In UK, it affects around 3 million people with 2/3 undiagnosed, males more than females, responsible for 1/8 of the emergency hospital admissions and 5% of deaths in the UK. Causes are tobacco smoking, 90% cases, occupational exposure like coal, silica or welding fumes, air pollution, genetic bronchial hyperresponsiveness, alpha-1 antitrypsin deficiency, poor lung growth and development, Example, low birth weight or infections, incidental chest X-ray, CT scan abnormalities. We have already seen. Diagnosis suggested by history, signs, and baseline spirometry. Consider patients with more than 35 years with a risk factor for COPD, generally smoking, and typical symptoms of SOB on exertion using an objective measure, example MRC dyspnea scale, to grade breathlessness, chronic cough, wheeze, regular sputum production, and frequent winter bronchitis. MRC dyspnea scale. Degree of breathlessness related to physical activity. Grade 1. Not troubled by breathlessness except on strenuous exercise. Grade 2. Short breath when hurrying or walking up a straight hill. 3. Walks slower than contemporaries on level ground because of breathlessness or has to stop for breath when walking at own pace. Grade 4. Stops for breath after walking 100 meters or a few minutes on level ground. Grade 5. Too breathless to leave the house or breathless on dressing or undressing. Used with the permission of Medical Research Council. If diagnosis is suspected, also ask about weight loss, effort intolerance, walking at night, baking at night, ankle swelling, fatigue, and occupational hazards. Chest pain or hemoptysis is uncommon in COPD. If present, consider an alternative diagnosis. So this one is an MRC dyspnea scale. Signs of COPD may be none. Possible signs are hyperinflated chest or poor chest expansion on inspiration, decrease in cricosternal distance less than 2 to 3 centimeters, hyperresonant chest with decrease in cardiac dullness or percussion, wheeze on quiet breath sounds, paradoxical movement of the lower ribs, use of accessory muscles, tachypnea, pursing of lips on expiration, use of pursed lip breathing, peripheral edema, cyanosis, JVP, raised cachexia. Spirometry predicts severity and prognosis but not disability or quality of life. Measured post bronchodilator, example 200 micrograms of salbutamol via a spacer. Diagnose airflow obstruction if FEV1 by FBC less than 0.7. Grade severity according to the reduction in FEV1. Severity of COPD and expected clinical picture. Stage 1. FEV1 more than 80%. There is cough, little or no breathlessness, no abnormal signs, no increased use of services. Stage 2 or moderate FEV1 50 to 79% of predicted. Breathlessness, wheeze on exertion, cough plus sputum, some abnormal signs known to GP, intermittent problems. Stage 3 severe. FEV1 30 to 49% predicted. SOBOE, marked wheeze or SOBOE. So shortness of breath on examination, marked wheeze or cough is present, and usually other signs are there, known to GP and specialists with frequent problems and admissions. Stage 4. FEV1 less than 30% of predicted, very severe. As for stage 3, but more breathlessness, severely restricted activities of daily living. Reversibility testing can be misleading, not routinely recommended. More than 400 ml increase in FEV1 following a trial of bronchodilator or prednisolone suggests asthma. Clinically significant COPD is not present if FEV1 FV1 by FBC return to normal after drug therapy. PEFR. Patients with COPD have little variability in peak expiratory flow rate. Serial home PEFR measurements help distinguish between asthma and COPD. PEFR may underestimate the severity of airflow limitation, and normal PEFR does not exclude airflow obstruction. Other investigations organized in primary care, chest X-ray and CT to exclude other diagnoses like lung cancer, FBC to identify secondary polycythemia or anemia, BMI, alpha-1 antitrypsin. If early onset COPD or family history is present, ECG, echo, serum natriuretic peptide, or if cor pulmonary is suspected, sputum culture. If purulent sputum is present, pulse oximetry to assess the need for oxygen therapy. Differential diagnosis is asthma, bronchiectasis, heart failure, lung cancer, interstitial lung disease, anemia, tuberculosis. Refer for specialist review if diagnostic uncertainty. Comparison of COPD and asthma. COPD and asthma, symptoms less than 35 years, rare, is often in asthma. Smoking history, nearly in all cases of COPD, may be in asthma. Breathlessness, persistent and progressive, poor response to inhaled therapy. If good response, reconsider the diagnosis in COPD. In asthma, there is variable breathlessness throughout the day from day to day. Good response to inhaled therapy is typical. Chronic productive cough is common in COPD, whereas uncommon in asthma. Waking at night with cough and wheeze is uncommon in COPD, whereas it's common in asthma. Management of COPD. Develop an individualized treatment plan for each patient. Review one more than once in a year, record spirometry results and progression, BMI, current symptoms, problems since last seen, exercise tolerance and smoking status, educate patient or family about COPD medication and self-help. Non-drug therapy, smoking cessation, most important, improves the outcome, vaccination. All patients with COPD should have an influenza and pneumococcal vaccination, pulmonary rehabilitation, lack of exercise decreases the forced expiratory volume 1. Multidisciplinary pulmonary rehabilitation is often proven of benefit. Refer the patients who consider their COPD hinders everyday activities. Nutrition. Weight loss in obese patients improves the exercise tolerance. Cognitive behavioral therapies can help patients who find the sensation of being breathless frightening. Screening for depression. You have to do screening. Smoking and COPD. FEV1 as a percentage of value age 25 years. So for a person who is aged 25 years, the FEV1 and you compare it with age 60 years and 75 years. For a non-smoker is 85%. So FEV1 decreases with age. Ex-smoker or quit age 40, 60%. Ex-smoker or quit age 60, 33%, that is severe symptoms. Ongoing smoker 33%, that is severe symptoms. Age 75 years. At 75, non-smoker is 80% FEV1, ex-smoker is 45%, ex-smoker quit at 60 is 15%, that is severely disabled, and ongoing smoker is dead. Rescue medication and escalation plans, management of acute exacerbations, long-term drug therapy. We will read. Document effects of each drug treatment on symptoms, quality of life and lung function as tried. Step 1. Offer a short-acting beta agonist salbutamol inhaler 1 to 2 puffs as needed or short-acting muscarinic agonist SAMA. Both increase the FEV1 and decrease the breathlessness. Step 2. Add. If asthma features are present, some steroid responsiveness, add long-acting beta 2 agonist plus inhaled corticosteroid, fluticasone or vilanterol. Fluticasone and vilanterol combination, LABA, and steroid. If no asthma features are present, long-acting muscarinic agonist LAMA and LABA, vilanterol and umeclidinum. So this is a LAMA and LABA combination in used in COPD. If no asthma features, this is the second line. Step 3. If asthma features or steroid responsiveness, then continue short-acting bronchodilator and change long-acting. If there is steroid responsiveness, continue the short-acting bronchodilator, change the long-acting medication to a LABA or LAMA plus inhaled corticosteroid, fluticasone, vilanterol and umeclidinum. So triple therapy if there is response to steroid. Spacer devices, nebulizers, add-on therapy, oral mucolytic therapy like carbocystine. Consider if chronic cough is present and sputum. Discontinue if no symptomatic improvement. Oral prophylactic antibiotics, azithromycin 250 mg 3 times per week. Offer if non-smoker or ex-smoker, optimize inhaled therapies and has undertaken pulmonary rehabilitation, but frequent more than 4 per year prolonged exacerbations are present with sputum production or hospitalization. Before starting, check the sputum for microscopy. Culture sensitivity to exhalation-resistant organisms of Pseudomonas aeruginosa. Baseline LFTs should be done and ECG for prolonged QT interval. Advise a small risk of hearing loss or tinnitus. Review after 3 months and then every 4 to 6 months. Only continue if benefits are more than the risk. Doxycycline 100 mg is an alternative to azithromycin. Long-term oral steroids. Avoid if possible. To avoid if unavoidable, keep dose as low as possible and provide bone protection. Theophylline MR. Used only if inhaled LABA or LAMA is ineffective or unable to use inhaled medication. Monitoring of serum levels is required and be wary of drug interactions, especially with antibiotics. Roflumilast specialist initiation only, adjunct to bronchodilators for patients with severe COPD with a history of frequent exacerbations. We will stop here today, and we are at page number 287. We'll continue from page number 287, management of COPD, tomorrow. Thank you. Have a good day.